right, and then here is our post-operative nursing care. So the post-operative period, this starts at the completion of surgery when we transfer that patient physically out of the OR. So patients are typically taken either to the post-anesthesia care unit, which we call PACU, the same-day surgery unit, or ambulatory care unit, or they might go up to the intensive care unit, the ICU. So for patients who underwent general anesthesia, post-operative care is usually provided initially in the PACU, and this is where we have skilled nurses who can closely monitor a patient's recovery. So the purpose of the PACU, which again is the recovery room, is the ongoing evaluation and stabilization of patients to anticipate, prevent, and treat any complications that might arise after surgery. So the PACU nurse is skilled in the care of patients with multiple medical and surgical problems immediately after surgical procedures. So this area requires in-depth knowledge of anatomy and physiology, anesthetic agents, pharmacology, pain management, extubation, and surgical procedures. So the main priority in the PACU is protection and maintenance of the airway and ensuring adequate ventilation. There are a lot of potential complications arising after a surgery, so our recovery nurses need to be really skilled in assessments and able to make quick decisions if emergencies do occur. So these are some of the risk factors for postoperative complications. If a patient has any of these issues prior to surgery, there are specific things we want to watch out for in the postoperative period. A patient with any degree of immobility is at higher risk for respiratory compromise, thrombophlebitis, and pressure ulcers. Anemia can lead to decreased oxygenation and poor wound healing. If a patient has hypovolemia, then we can easily see decreased cardiac output and decreased tissue perfusion. Any type of respiratory disease can lead to respiratory compromise. If the patient has an immune disorder, he or she is at higher risk for infection. A patient with diabetes might have gastroparesis and delayed wound healing. Coagulation defects can increase the risk of bleeding. Malnutrition can cause delayed healing. And obesity places a person at higher risk for dehiscence or evisceration. Dehiscence is when a wound opens back up after it was sutured or stapled shut. If this happens, you should apply a sterile, non-adherent, or saline dressing to the wound and notify the surgeon. Also, tell the patient to bend the knees and avoid coughing. Evisceration is when there is a wound opening with actual protrusion of internal organs. This is a surgical emergency, so one nurse should tend to the patient while another nurse immediately notifies the surgeon. We already talked about most of this when we talked about preoperative care, but one more age consideration to keep in mind if you're caring for the elderly postoperative patient is that a rapid return to his or her level of pre-surgery orientation might not be realistic. Preoperative drugs and anesthetics often are going to delay that older patient's return of full orientation. Readiness to leave the PACU or to be discharged home is based on a recovery score, usually assessed by the modified Aldrete scoring system. So typically, we want to see that the patient has a score of 8 to 10, which indicates that the patient is pretty much back to baseline. Other criteria are going to include stable vital signs, normal body temperature, no overt bleeding, and then we need to see a return of gag, cough, and swallow reflexes, and they need to have the ability to swallow liquids. If our patient is not discharged home, the assessment continues in the medical surgical unit. Keep in mind that during the post-op period, all patients remain at risk for pneumonia, shock, cardiac arrest, respiratory arrest, DVTs, and GI bleeding. So there are some specific interventions and assessments that we want to do. For airway, we're going to monitor their SATs, assist with coughing and deep breathing, and we want to encourage use of their incentive spirometer every 2 hours. We want to position them to maximize their ventilation. We don't want to put a pillow under their knees because it can decrease their venous blood return to their heart. When your patient's ready, you should encourage ice chips and fluids and provide oral hygiene. Pain should be assessed frequently. We want to educate on the use of a PCA if they have one, monitor for side effects, and be sure to pre-medicate before ambulation or other painful procedures. To assess renal function, keep an eye on their I's and O's. Their output should equal their intake. Additionally, a lot of people have trouble voiding after anesthesia, so monitor for bladder distension. And then as far as bowel function, we don't want to feed them until we start to hear some bowel sounds and they begin passing gas. As you're going to learn in simulation this quarter, thromboembolism is a potential complication, so we need to keep watch for those signs and symptoms. We want to keep an eye on all of their incision and drain sites to monitor for excess output or for signs of infection. In some cases, you're not going to be changing the dressing, but you should still be assessing it to make sure that it is clean and intact. This little picture gives an idea of some of the complications that can arise postoperatively. We want to monitor for choking, noisy, irregular respirations, any decreased oxygen saturation, and cyanosis. These could all indicate an airway obstruction. Hypoxia would be evidenced by a decrease in oxygen sats. Hypovolemic shock can result from a massive loss of circulating blood volume, so monitor for decreased blood pressure, decreased urine output, increased heart rate, and slowed cap refill. A paralytic ileus can occur due to absence of GI peristalsis, so monitor those bowel sounds, encourage ambulation, and only advanced diet as tolerated. We can also see some wound dehiscence or evisceration. So again, if it occurs, call for help, stay with the patient, cover the wound with a sterile towel or dressing that is moistened with sterile saline, and do not attempt to reinsert the organs.